All right. Good morning, everybody. Welcome to today's webinar, Revenue Regeneration Strategy for Provider and Networks. I'm Kishan Srinivas. I'm a Senior Director for Products at Innovaccer. On behalf of the Innovaccer family, I extend a warm welcome to all of you. It's my pleasure to introduce two very distinguished leaders at Innovaccer, Dr. Nace, our Chief Medical Officer, and Evan Grossman, our Chief Product Officer. Dr. Nace, would you be kind enough to give a quick introduction about yourself to our attendees today?
Yeah, thanks, Kishan, and it's a thrill to be here today and talk about this very important issue, revenue regeneration strategies for providers. Physician by background, family medicine and psychiatry both because of the importance of social determinants, and 30 years of working toward technology and the importance of data. So there's so much we can do, and happy to be here.
Thank you. And Evan?
I'm no longer muted. I'm Evan Grossman, and have been in healthcare technology for 10 years. I don't think there's ever been sort of a clearer moment where, and I know very few people get into healthcare for the money, but the truism, no money, no mission, has never been clearer. And without a strategy for bringing the revenue back, the ability to continue to, serve the communities we serve and practice healthcare is really at risk. So that's why I'm excited to talk about this.
Awesome. Thank you both. One of the things that I noted over the last quarter is, I think Evan, Dr. Nace, both of you have had a busier work day than ever before, right? So I know between the two of you, you've met about 1,500 odd healthcare leaders from across United States. So my real intention of today's webinar is to see how I can engage you in a conversation and get you to share a lot of the insights that you've uncovered as a part of the these discussions. I think as a plan for today, I want to break down our discussion into three broad sections. To start with, I want to just go back and recap the impact of COVID-19 on providers and patients. I have some statistics here that I want to kind of talk to you about. And I also want to get your subjective opinion on what that's meant for different stakeholders in the ecosystem. I then want to switch our focus towards trying to understand and articulate the new normal for healthcare as a whole, and providers in specific. I'm interested to hear more from you on what that new normal is likely going to look like and what it's going to take providers to be successful in that new normal. As we go down the conversation further, I do want to spend some time trying to get your insights on how providers could start thinking about regenerating revenues as they make the switch towards the new normal, right? I hope I'm not going to put you on a spot anywhere. I'm pretty excited about how this is going to go forward today. So when you talk about the impact of COVID-19, I think the first fact that jumps onto me is the cumulative revenue that providers across the country have lost since March, from March to June 2020. That number is about $161 billion due to all the canceled hospital services. Now, Dr. Nace, what has this meant for providers across the country?
Well, that's a great question, Kishan, and it's of such great importance to our healthcare system. So for large health systems, they've had lots of reserves, and this has made a dent in their reserves, and they've had to rethink their budget for the year and how they're going to recoup their reserves as they move into thinking about the end of the year. For the smaller hospitals, particularly in rural and more suburban areas, they don't have as many reserves, and they're verging on the edge of being bankrupt, and in some cases have gone out of business. I know places like Kentucky, West Virginia, we've seen some closures, and they serve critical needs to their communities. For networks of providers, independent provider associations, independent practices, this has been potentially devastating to them. They've had to close their practice either temporarily and in some cases permanently, and start to think about, how am I going to take care of my patients? And this is something I think we'll get into today.
Makes sense. Evan, anything that you want to share with the audience?
No, just that it's been such a rapid decompression, right? That I don't think anyone had ever prepared for. And so we can certainly talk about some of the silver linings, right? I think, the people that have been pushing for more telemedicine, thought it would take, 10 to 20 years to get to the level of virtual visits we've now seen over the last quarter. But that's a very small silver lining in an otherwise pretty dark landscape. And we'll talk a little more about what we can do about it in a bit.
Agreed. Makes sense. So when you look at the revenue loss, obviously a lot of that's come from the decline in patient volume. In the same period, providers have seen as much as 56% decline in their average patient volumes. Now, if you look at the same decline across different settings, what you see is that the decline has been consistent across all settings, with I think the outpatient surgery volume being hit the most by about 71%. And I think that's primarily the reason why the revenue loss number is so high. But there does feel like there's a silver lining to it now. While April saw the worst decline in patient volume, so this is a graph that talks to you about the decline in ED volumes. It came down to as low as about 1.2 million visits per week at the start of the pandemic. But what you see is it's slowly been picking up, right? It's been picking up all right, but it's still nowhere close to the range it was at the similar time last year. So what does this essentially mean, Dr. Nace? So does this mean that patient volumes are kind of bouncing back, and it's just a matter of time before people start seeing more patients in their in their practices, or does this mean that we're going to continue to see a big difference between the patient volumes this year as compared to last year's?
Well, good question. There's a number of things I see here, and actually it looks very similar to what we've all seen on the news recently around COVID cases. However, we know that COVID cases are starting to increase. So this data is a little bit lagged as we see April 27th. It's a little bit beyond that now. So some of the questions that are deep in this data are, will people return, like in this case, to the emergency department? Are there other ways to deliver care for those patients? Will they avoid unnecessary care? Will COVID cases increase and the pandemic worsen? If so, will they then receive care, and in what way? So lots of questions here.
Yeah. Evan, what's your take about this? So this is representative of what's happening broadly?
Well, I think it's always dangerous to sort of declare a disaster over and say, oh, look, right? As I think we're seeing, with the increase in cases in some states. Likewise, I think the interesting question is, if the decrease in ED utilization were just people who had unnecessary care not going to the ED, we would all be celebrating, right, from a triple aim perspective. I think that the problem is that that's unfortunately most likely not the case. There's an interesting story in the Times about sort of the increased acuity around cardiology. So, for example, people showing up in the ER with, ventricular fibrillation instead of going in earlier with chest pains, right? So there's certainly a very strong potential that what's happening is we're actually increasing the cost of care, and people that need care are not getting it. And that's just in the ED example. We can talk a little bit later about the long-term impact of the dramatic decrease in elective screenings like colonoscopies and mammographies, right? Because the later that one actually catches cancer, the higher the cost, the greater the impact on the patient. And so I think there are going to be some fairly significant long-term consequences to the decreased volume of the past 4 months if we don't come up with the right strategies to bring that volume back.
Those are great points, Evan. I'd like to point out that we really don't understand the data behind what we're seeing here, which is, might that increase because people delayed care when the initial pandemic came out, and as you pointed out, came much later than they would, which potentially leads to a worse outcome? Might that have led to increased hospitalization once they arrive at the ED? Or is this a delay in people receiving care from an ED that they could receive elsewhere, sort of not needed? I remember patients of mine would go to the ED to get wound supplies, post-op, and I'm like, that's not a great place to get wound supplies. They're like, well, it's convenient. So we don't know what's behind this data. I think the new normal will settle out, and it'll be very interesting to see how that plays out.
Sure. Those were great insights. As we move on further, I think I just want to take a quick pause point here and understand what our audience has been seeing as a part of their day-to-day practice. So we'll do a quick poll here at this point. And we're interested to know from you how COVID-19 has impacted your organization's revenue. Has it had no impact at all? Has there been some minimal impact, but you feel like you're back on track now? Or do you feel like the revenue loss was significant, but you're now making progress? Or do you feel like the revenue hit was so significant that you still need to work on ways to figure out revenue regeneration? So you're going to have the poll appear on your screen.
These are great questions, John. It's interesting. We have a complicated landscape in this country of urban, suburban providers that geared up for this, different areas that have been hit by the pandemic in different ways. Evan, I know you've had some thoughts about your work with clients and looking at some of the data. What are some of the things you're seeing?
Yes, certainly I know I've unfortunately not talked to anyone with the no impact on revenue. And obviously we'll talk a little more later, but for the impact on revenue, there's then, very significant knock-on effects. So, I've talked to a lot of practice leaders who've had to cut staff or reduce pay, who've had to sort of, temporarily shutter spaces. So I think there's been some pretty strong impacts, all at a time when people are asking frontline healthcare providers to step up and do more and put themselves more at risk. So I think there's been, just dramatic impacts far beyond the revenue here.
Absolutely.
Yeah, it would be really interesting to see what our audience has to say.
Yeah. And I am okay.
So, Evan, now you've met some, at least virtually, some folks that have had no impact on revenue. So,
great.
This is fascinating.
I'd love to ask them if they were lucky or smart, right? Because were they in the just happened to be in an area or a part of healthcare that wasn't impacted, or was there some foresight or planning or other things they did that impacted it? Because well, I'd rather be lucky than smart any day. It would be interesting to understand a little more if someone wants to. Those who saw no impact, put in the chat sort of why they think they were spared would be kind of interesting.
But this is really good news. I mean, 60% of people are working on it and they're making progress. And so that is really refreshing. I think the kind of collaboration we can see in the environment of people learning from others, this is good news. I think we're going to get ourselves out of this hole.
Yeah. Excellent. So I'll move on to our next section. Here's where I think, Dr. Nace, I have an answer to one of the things that you were asking. So I also dug into some data which talked about where this a shortfall in ED volume is coming from, right? And clearly, it's not just about people that would have shown up in the ED, where they could have gone to another venue. What's evident is that we are seeing a lot of people that are in greatest need of care that are skipping ED utilization, right? Evan, you did speak about like the impact that this patient volume might have on the health of communities itself. So could you just elaborate a little more about your thought there?
Yeah, no, as I said earlier, I think that what's going to be the biggest challenge is how can we proactively, especially when we talk about preventive screening or early diagnosis, get people the monitoring they need and the screening they need now so it doesn't get even more acute. right? And so if we know that a large number of people who needed care didn't get care, how do we triage? How do we segment? How do we understand, right? Because, we'll talk more about, different protocols for reopening and other things, but, always, most doctors I've talked to say rarely are the patients they most need to see the ones who are in the waiting room. But I worry that's going to become even more true as we start reopening, and trying to be a little more proactive is going to be really important.
Yeah.
Yeah, and this is really interesting to see that the children are really the folks that are really avoiding, right, that early pandemic period. So, but it's good news. People are starting to come back, and the question is are they waiting too long for the kind of care?
Yeah. And that's why, as you try to understand what Americans are thinking in general, one of the popular perception is that they feel a doctor's visit will put them at a higher risk of COVID-19. How true do you think this is? Does that make sense? Like, do you relate to this sentiment as well? I know I'm putting you on the spot, but
yeah, I certainly. I mean, I tend to be pretty shy about going to the doctor anyway, but I certainly, for anything that's even marginally elective, I couldn't imagine, especially why I would want, and as loath as I am to go to my provider, and obviously one shouldn't do market research on themselves, like I try and avoid hospitals at all costs, and certainly anything that's even remotely elective, I personally couldn't imagine right now until I knew a lot more about what they had done to segment their populations and ensure the likelihood of infection from a healthcare worker from another patient was much lower, or transmission.
Yes, it's very interesting. I live in an urban environment here in San Francisco. Urban environments are very different because there's less space, it's more crowded. I'm scared to go to the grocery market. And when I do, because our grocery markets are relatively small, I actually have a telehealth visit later this afternoon because I'm nervous about going to the clinic. I hadn't shared with anybody before, but I actually made an appointment to go in because the clinic's open, and then I got nervous, and then I pinged them and I said, could we try telehealth? They were new to that, and now they've set it up. So yeah, I mean, I think even those of us who are enlightened think about grocery stores being concerning, and because of the nature of the people that need to be seen in the clinic, concerned about that as well.
Makes sense. Yet, when patients are asked, what is it that would make them feel comfortable to come back to seeing the provider, it's surprising that 50% of them feel like they would come back if they were given certain assurances, like, is the provider willing to see me? Are the COVID-19 procedures clear at the provider's place? Or is the provider location certified free of COVID-19? So looks like there is a lot that providers can still do to influence the behavior, that the care-seeking behavior among their own patients. So Evan, you did speak about some of those examples, like having all the other ways of delivering care, like have drive-through testing. So looks like the data does point out to the fact that providers do have the ability to exert some influence in terms of how their patients start seeking care in the near future. Don't you think so?
Oh, absolutely. And I think what this data is showing is it's really important for practices to reach out to populations, to tell them what they're doing, to show them how they're doing it safe. Keishan, you're relaying the conversation we had earlier off the webinar about drive-through testing, right? So I'll share that with everyone else on the webinar. We're talking to one practice that had come up with I thought a very creative hybrid annual wellness visit approach, where they basically told people, look, we're going to do your visit via virtual health, and our phlebotomist is set up in the parking lot, and we're doing, drive-through blood draws. If you need a vaccination, or we need to check INR or do a cholesterol screening, we'll do that while you're in your car, right, with someone who's in full protective gear. So it's very safe. You won't need to come into our office, and you will be, and you will be able to see the doctor over the video. And they feel that that's really helped get their preventive screenings up significantly. Obviously not mammography, colonoscopy, but certainly the A1C, INRs, a bunch of other screenings that they're doing, and they're getting their and they're getting reimbursed the same as if they're in inpatient visits. Their lab revenue is back up, so it's been a very successful strategy. Not everyone has a free parking lot, but I would think most practices could create a segregated area that could be very safe with social distancing for just blood draws or vaccinations.
Absolutely. I think, yeah, so my key takeaway from this discussion is, yes, there has been a significant decline in patient volumes, and that's led to revenue losses for providers across the country. However, things are looking like it's moving towards a better place. So the patient volumes are somewhat picking up. But I think the most encouraging part that we just saw on that slide deck before was the whole fact that providers can exert significant influence in bringing back some of this patient volume so that they do the right things for their patients as well. Moving on, I did want to spend some time talking to you and understanding you from you about what you think the new normal for providers is going to look like. I think the COVID-19 has actually told us that world's never going to be the same. We'll all have to make tweaks in terms of how we adapt to this new normal. So what have we been talking about to our clients? So what does this new normal look like, and what can healthcare organizations do to win in this scenario? Dr. Nace?
Yeah, absolutely. I think about that last slide and the data, and then in Evan's comments, and then thinking about this first section, engage your patients proactively. So I've been fortunate. My health system has actually kept weekly communication with me about what they're doing for COVID, what I should do if I'm having symptoms or being sick. They've actually sent me pictures from my primary care office to show me that there's 2 people at the entrance where they're taking temperatures, asking questions. They showed me the waiting room where every other seat is blocked. And they described the procedures to me and given me guidelines for when I could access them in a different way, telehealth. So they've grown.
So David, we should write a tale of 2 practices, because my primary care doctor has sent me nothing other than sort of a note in my care that like they're no longer renewing my Lipitor and I need to schedule an appointment for August.
Well, we're on opposite sides of the country, so we'll connect our health systems for sure. But I think it goes to, also they may be behind the scenes just getting their virtual practice thought through, and they may not know what to communicate. So I think building that, growing it, building resiliency in their operations, thinking about their staffing, and then really evolving and learning and adapting and being more maybe proactive in my case, and maybe behind the scenes working on it, Evan, in your case.
Excellent. And Evan, I know both patient engagement and virtual care has been a big part of your focus in the last 4 months or so. So what have you seen working very well for our clients overall? So who do you think is doing a great patient engagement within our clientele, and what are they doing right so that that could actually serve as a primer for some of our attendees as well?
Yes, so I mean, I think David enumerated a lot of best practices around letting people know you're open for business, either via a video visit or in person, but encouraging video visits, especially when the reimbursement levels are the same. And I think, what's true in any type of outreach is segmenting correctly, right? Knowing the cohorts, knowing, okay, who doesn't even really need, we can do, a PHQ-9 online, we can do other assessments online, we can have a good visit with the doctor, and then if there's any, follow-up, if there's, blood draws needed or whatever, we have a good segregated way to do that. Also, I'll just put in, my pitch for lowering healthcare costs over the next 20 years. This is, while it may be harder to do over the phone, now's a great time to reach out and do end-of-life planning, right? And, you're getting paid a lot right now by Medicare for doing it, the same as if it's in person. So, find out if people have call up people who don't have an advance directive. It's certainly something that's probably on their mind if they're, over a certain age. And, people are enjoying engaging with their physician in this new way. Is the doctors I've talked to have been really impressed with the quality of some of the conversations they've been able to have with their patients. And it's a very different, obviously it's different when you're not putting hands on someone, but it still can be very rewarding for both sides.
Yeah, I really like this point about knowing your cohorts. Traditionally practices aren't data driven. And I think now's the time for them to sort of recoup and think, who are the patients that I should be reaching out to quickly? What are the services I should be offering them? Who's at risk? And more importantly, like, how can I provide these sort of data collection and information, such as end of life planning, get people involved with things, do annual wellness visits? Can I do it virtually? Can I do it in person? Can I make my environment safe? Can I communicate with people? But stratifying and identifying which patients need which approach is something that's new for many practices. It's all about the data.
Makes sense. But don't you think it's still a pretty different volume altogether? Because on an average day, you're used to getting calls from 10, 15 of your patients from your panel, and you schedule appointments for them. But now you're talking about reaching out to your entire panel, right? So you've got a bigger population to reach out to, and you're fundamentally talking about a very different way of outreaching to patients. So
Sure.
How to provide scope with that kind of volumes?
I think you're setting up the next slide, right, Kishan, right? Because obviously, being more proactive requires a more automated approach, right? So the ability to understand which of your patients would prefer a text message, would prefer an email, would prefer maybe a robocall that then they could transfer to someone live in the practice, and reaching out to them with a clearer message, again, within the constraints of HIPAA, but hey, your doctor feels it's important that you see her in the next few weeks. Click here to learn how we can do it in the safest possible way, right? And so giving them a message that you really are focused on the patient's safety, but also that it's important for their health that they be seen, as it is for some of these cohorts. And I don't think there's any way you can do that just by having your front desk people, dialing all day long. It's probably not a very effective way to do it, and using, some of these crazy new things like the internet is probably a reasonable approach.
This is a great point, Evan. A lot of times people have pointed out that their veterinarian takes better proactive care of their pets than their primary care practices do, or their specialty services do, meaning that we're used to handing a patient an appointment card when they leave, and then expecting that they will call to make that appointment or arrive at the date they've chosen. In many cases, that doesn't happen, and that doesn't even speak to the patients who have not been in the office. So taking a look at your panel, this is a great opportunity to, like many folks have done as a result of this pandemic, modernize your office, rethink your approach, take a pause, and think about how could I do things more proactively and better serve my patients. So excellent points, Evan.
And never have you had probably a better excuse for making changes, right? No one is gonna, complain like, that's crazy that I can't come in whenever I want. Right? It's like, well, no, like we've set aside these office hours for certain that, right? And you can do a lot of interesting changes and just blame COVID, even if they're going to be the right changes for the long term.
And this is really all about a move to more patient-centered care. So this is awesome.
Absolutely. And I was talking to one of our clients who've recently gone live with one of our own patient outreach solutions. And what I understand from them is that they see their roles transforming now. So they've gone away from being people that used to call patients and schedule appointments to now they're talking about most of those tasks getting done by through outreach, automated outreaches. And they're now focusing more on how to influence, give those additional nudges to people that really need that extra nudge, right? So now they're looking at what's been the campaign outreach like, what's the performance, and how do they, what is the population that is still not engaged, and how do we now go and be more focused around bringing them back to the clinics? So
right, I mean, look, there's always a response curve, right? There's some people who, as soon as they get an email, are going to click and are going to set up an appointment, and that's going to be great. But then you're going to have other folks who are going to be much more resistant or not respond and may need a more personal approach. So knowing, right, and look, we have a lot of experience at Innovaccer, which we share with our clients, but there's a lot of really interesting marketing that goes into writing the right email. I still remember a bunch of A/B testing we did to get people to do mammography, right? And it turned out the most effective subject was, our mammography machine is lonely. Like that was the most effective subject to get people to schedule a mammogram, which was not like, you could die of breast cancer, or it's time for your screen. It's always it's rarely intuitive what works, and so this is a time where I would expect a lot of practices to do a lot of trial and error on what are the right proactive outreach. Reaching out to certain demographic groups is much easier than others, right? It's often easier to get people to come in for well child visits than to care about themselves, right? So there's a lot of things you should be tracking and ensuring you're actually then getting the right number of people into the practice.
Oh, there's a great comments. How many of us have thought about our aging parents and how we visit them, look at their surroundings, listen to their complaints, and say, why you need to see your doctor, or you should get this medicine refilled. And they say, well, I didn't want to bother, I wasn't sure, I'm kind of nervous, it's this pandemic. And so how many of us think about what we need to do, but the office isn't identifying them or reaching them out? Awesome suggestions, Evan.
Yeah. And so that's engaging your patient, right? So knowing your patients well, being able to reach out to them in the way that makes most sense to them, and actively keeping a track of what's happening with each one of your patients' health status itself. That's great insights. The second thing that Dr. Nace mentioned was, like growing your virtual care practice. And Evan, I know you and I have been talking about virtual care for a really long time, but like since March, you completely double down on your focus. You've been wanting to do virtual care, creating a solution that makes a difference for our clients. Can you share your thoughts on what is so different about our virtual care solution? What are you trying to solve for our clients that wasn't already being met by their existing vendors?
Yeah, so I mean, I think that the thing that's important with virtual care is it's not just about creating a way to do a video chat with the provider, right? Most practices have a pretty well thought out workflow of capturing information at the front desk, potentially capturing assessments and other key screenings even before the appointment, then having an MA do a med rec and do some other, collect vitals, do other things, then rooming the patient, having the provider then come in and do the exam, and then potentially some post-exam orders around, whether it's, vaccinations or testing. And so coming up with a virtual way that actually has that right workflow, the ability to send patients a screening ahead of time so they can complete it, the ability then to have the patients go to a virtual waiting room where they know the provider's waiting for them, but perhaps first they're seen by the med rec who's, confirming their pharmacy, confirming meds, confirming allergies, doing a range of things. And having, most of our larger clients are in a multi-EHR environment, but having a system that works very, it's on top of their EHR, doesn't get in the way of their EHR, still lets the clinicians document the visit in the EHR, both for, the longitudinal record and reimbursement purposes, but, allows them to have sort of an engaged visit with their patient is really important. And, the other thing that I think has become important is, and I think, I'm not sure we ever fully paid attention to how many people came into the exam room or the waiting room with a given patient, right? Whether it was a parent or a caregiver, but it's pretty clear that just allowing one-on-one video visits doesn't meet needs for 30 to 60% of the visits, depending on the practice. And so having a way to have another engaged party, you know, again, whether it's a parent, care, you know, a child, someone else, is important.
Yeah,
Nace, what are you?
Evan, I've always said that, you know, healthcare should be a team-based sport. And we need to learn to not only work as a team and better deploy a team. It's not always about just seeing the doctor, but also how do we get more efficient at what we do? I mean, how many of us think about the friction in healthcare? We take a day off of work, we drive, we park, we wait in the waiting room, we get handed a clipboard with paper to fill out for questions that we've already answered on paper a gazillion times. We hand it to somebody, it might get entered or not. They're on a different system or EMR. Go on and on and on. We leave the office, we don't remember what was said. There's so much room for efficiency, and teamwork is the way.
Yeah, absolutely. One of the things that I heard from one of our clients that went live in May is that their existing solution provider you know, would typically lead to very high call failure rates. And what we realized as we started figuring that out was it wasn't nothing to do with the tool itself, but it was just the fact that their patient panel has such wide range of patients, like people that are extremely tech savvy to people that are not tech savvy at all, or people that don't know how to use much beyond probably clicking a link here and there. So so what I've realized is that when we are trying to create this entire virtual care practice, when organizations are looking at it, the solution does have to be something that fits everyone, and it is not just one size that fits everyone, right? So key things like you talked about the variance, Dr. Nace. So I think one of the key things that I've seen here is the whole need to download an app has been a definite you know, a thing that everybody questions, like, do we need another app on a smartphone? What else do you think, Dr. Evan, key when you're thinking from the patient perspective?
Yeah, no, and let's be clear, for our more or less tech savvy aging population, their tech support people are not in person anymore, right? Whether it's their children or their grandchildren, who are the ones who often will and that's not everyone. Obviously, there's some incredibly tech savvy 90-year-olds, but they're, you know, by and large, they're, you know, as people who did not grow up with smartphones aren't as savvy about downloading apps and using them. And what I think has made this crisis even worse is that, you know, the people they normally rely on, whether it's a neighbor or someone else, they're not having personal contact with, and they're not walking up to them saying, hey, could you help me out with this thing on my smartphone? So coming up with, you know, solutions that will meet the broadest, right? So whether it's like, yeah, if you want an app, we've got an app, but or you can just go to this web page, right? Or just dial this number and we'll do it via voice, is important, so that you can really get to patients in however they're comfortable.
Sure. Yeah, there's a great point. You know, think about that clipboard with the piece of paper we get. I'm not used to being asked at my provider is like, do you have a cell phone? Do you prefer to be communicated with by telephone? Would you be interested in an application that you communicate with us? So on and so forth. Have you learned how to get to your medical record or information online if we have such an anymore? No one ever asked these questions. So I think it's important to then think about stratifying people, not just about risk, but also their technology capabilities and preferences.
Right, no, and I think it's also an interesting challenge. I'm just gonna diverge from, yeah, give everyone a very quick tip for when your practice opens up, or you can do it over the phone. The thing we learned long ago is if your front desk person asks people for their email address, they rarely get email addresses, right? And it turns out the right way to ask someone for their email address is say, hey, would you like access to your health records or practice information online? And when the patient then says yes, you say, great, let me have your email address. And we've seen clinics go from like a 60% collection rate to a 90% collection rate. And what's increasingly important is actually having cell phone numbers so you can SMS, and email addresses so you can reach out, so you can then get to these volumes. And we see the practices that it's started laying the groundwork a year or 2 years ago on that having less trouble as they come back than practices that don't have as updated contact methods for all of their patients.
That's an impressive lift, Evan, just by the education to move up to 90%. That's very impressive. And something we should learn.
Yeah, I mean, look, in retail, they talk about the say no question, right? You never ask a customer like, can I help you today? Because they'll always say no, right? Instead you say, what are you looking for? And it turns out if you say, would you like access to your health records? Very few people will say no, right? But if you ask someone for their email, they're very suspicious. I don't know if I want to give that to you, right? So that turns out, and we learned that just by looking at the data and seeing this one practice that was doing a really good job at email. So we called them and said, hey, what are you doing? And that's how we learned that.
So that's a great insight. And coincidentally, there's also a question from some of our attendees. One of them says, how can physicians ensure personal relationships when they're practicing virtually and when they're automating outreaches? So Dr. Nace, what's your thought around that? So how can physicians ensure that the relationship still remains personal with their patients despite the technology barrier?
Right. So think about, one of our physicians here, Dr. Paul Grundy, likes to tell this story about how when he would fly on a certain airline, they would meet him and say, "Oh, do you still drink Glenlivet's on the rocks?" And he's like, "I haven't flown this airline in 4 years. How do they know that?" So think about those physicians who you really felt good about. They walk in the room because they've checked the information before they come in, and they say, so what's going on with Bobby, your son? Has he graduated this year? I saw that he was supposed to graduate. So they remember something, and that's a personal connection. So this comes back to the issue of how do we best use data? And I think virtually, if we can tee those things up so that they can make that personal connection by video, it'd be awesome.
Well, let's be clear, nobody remembers any of that. It's because it's stored somewhere in the record. So before you walk into the room, you see that they like, or before you walk on the plane, you know they like Glenlivet on the rocks. Before you walk in the room, you've made a note at the last visit that their son's going to graduate in 2020, right? I mean, it's,
Sure.
Right. None of us have, maybe some of us do. I don't have that kind of memory, right? But making sure you're storing those personal connection facts so you can reuse them later is critical.
Awesome. Evan, you've touched upon this already. So there's another question which is what factors influence engagement levels of patients? So you already mentioned some things like the time you reach, the topics you use. Dr. Nace has just mentioned like being able to make that personal connection. Is there anything else that in your view can improve the overall influence, the engagement level?
Yeah, look, I mean, I think it's tech savvy, it's age, it's comfort with the medium. I think most of the big ones, it's obviously having a workflow that really works, right? Where they feel like they're being, like, okay, you collected all the information up front. Now you're talking to me about it. I know how I'm going to follow up and get my, cholesterol level checked at the end of this, or how I'm going to get my blood pressure checked, right? Those sorts of things, so that they're comfortable engaging.
Absolutely. So moving on, Dr. Nace, I was curious to hear about this from you. Talking about building resilient operations, we've heard a lot about using data near real time, trying to see how you can bridge gaps in care, how you can streamline care, how you can shrink the care process. So what are your thoughts? How should health systems, hospitals be thinking about building a more resilient operations in this phase specifically?
Yeah, so I think for two stories, we had a large health system client here who, when the pandemic hit, they were like, well, we have all of these data systems. So this is a large health system where we can track our supplies, we can track where the vents are, we can track our personnel system to see where our intensivists are who qualified to do intubations. We can see where we have rooms for intensive care beds when they open up, but they're not all pulled together. So we're running into problems. We're not efficiently using our resources. So this is a great dashboard about how a large health system or a large network or practice can really keep track of their data in real time, which is a solution we provided for them. I think for small practices, I'll go back to my friend Paul Grundy and I, when we were starting the patient-centered medical home movement, we found these awesome practices who would celebrate the idea of who are the 2,000 patients in my panel and who needs a mammography. So it'll be mammography month based on guidelines. And they were desperate to get that number to perfection. And so it was like a competition. They'd make phone calls, they do drive-by. I live in that neighborhood. I'll go by and go knock on their door. I know that. So they would do everything to try to reach out. And basically they had data on paper. So this is a couple years ago where they would do that. Now we have technology that can provide that from the level of a small practice to a large health system. And this is an awesome example of how we can get smarter and better about achieving our goals in delivering healthcare and delivering good medical care to our patients.
Evan?
Yes, so I mean, I think that's just a great example, and I think as people are brainstorming on how their practice is going to regenerate revenue, don't underestimate the power of gamification. Of, the United Way does it with those simple little thermometer boards, right? But set goals for your practice, share them around. I can't tell you how many arguments I get when I go to a group of physicians and tell them that half of them are below average. And just tracking individual data and making it a little competitive, but with the winner being the overall practice as volumes come back up, is really powerful. And pick the right things to do, and then track it and display progress, and get the whole practice sort of working as one to reach some of these goals, which are going to be important, for the health of the patients and the health of the practice.
If you kind of have a minute, I want to say something about what Evan just said and tell a story. I went back when I was, before I came here to Innovaccer, was perplexed by this problem. We had a cardiology practice. I was working for a tech company, a health insurer. And we met with them, and we had all the data about which of their patients met a particular guideline. In this case, it was the use of beta blockers post myocardial infarction, heart attack. So it's a best practice, gold standard. Pretty much every cardiologist, most primary care physicians would say, absolutely, everybody who's had documented heart attack should be on a beta blocker in the first 6 months. And we would say to them, when we met this one practice, we'd say, what percentage of your patients have had heart attacks in the past 6 months do you believe are on beta blockers that you prescribe? Oh, probably 92%. I mean, there's a few cases where it's contraindicated, they're on other medications or other reasons. And then we said, well, we have data here to show you that it's actually 30%. And wow. The first reaction they had is they leaned forward, their eyes grew big, and they said, you lie. and they because it was an emotional reaction. And then we had a ream of paper that had it patient by patient. And we sat down and said, well, let's make sure, because we just want to make sure our data is correct. And we'd go through patient by patient, and suddenly you saw shoulders relax, and they'd say, oh my God, I had no idea. People don't know they don't know their data. They don't know what they do. They think when they see patient by patient, they're doing the right thing. But when they look at the greater picture, and this is true for practices, for physicians, for health systems, once they see their data, it's enlightening.
Absolutely. And yeah, I think these also have some of measures like these will have long-lasting impact on an operations, because like if you're able to use data effectively, and if you're able to ensure that your processes are streamlined and you're making diligent use of your resources, you're likely going to be able to improve your patient throughput in a big way. You'll be able to reduce your length of stay in a big way. And these things just add to your top line and bottom line in the long term as well, right? I do have another question, which is interesting. Dr. Nace, how should organizations plan on getting the elective surgeries up and running? What are the things that you think we should consider at this point?
No, absolutely. And we're doing this with some of our patients. We're not very good historically of identifying which patients are at risk based on things like the community they live in, what kind of social supports they have, as well as looking at other care they're receiving from non-surgical specialists. So, we call this, I mentioned the medical home and primary care, we call this the perioperative surgical home. It's a direct analogy. How can we really stratify our surgical cases by their risk factors, both on clinical risk and social, environmental, and economic risk, and then create a plan for them? And then once they come into the health system, and this is where as people come back to elective surgeries, we think very carefully about how can we compress and make much more efficient the flow of services from final diagnostic to pre-op prep to preparation to surgical procedure to post-op physical rehabilitation back to home, back to primary care, and do that with care coordination and care management when needed, based on all that other information about risk factors, and also how to keep the patient engaged and maybe their family or stakeholders during that process to make sure we're efficient, having better quality and better outcomes at a patient-centered point of view.
Awesome. Yeah, and it is very interesting because what you're essentially now doing is to look at the entire episode of care more longitudinally, right? So you're talking about identifying, you actually have elements of all the things that you've covered so far. Like you have the element of engaging patients proactively, you have the element of actively working with them, reducing their health risks, optimizing them through the journey of surgery itself. And this really gives you a way to start having the touch points, like giving the confidence to patients as well about the fact that they're in safe hands, right? So I think that's a great example. But then all of this, right? So when you're talking about, let's say, doing pre-surgical optimization, or so all of this essentially involves investments, right? So when you talked about investing in virtual care, when you talked about investing in patient engagement solutions, all of this essentially is more investments for providers. And given the current state where you already had a pretty significant dip in revenues in the last quarter, I think any investments has to be backed with how providers can actively start regenerating revenue too, right? So what's your view on that, Evan? Like, so how do people start thinking about this entire process now? Like, how do people really get around making these investments at this point?
Well, look, I mean, I think that the question is, if you don't make the investment, what's the cost, right? So if you don't make the right investments in segregating out facilities to convince people to come in for elective surgeries, no one's going to come in. If you just sort of open the floodgates and tell everyone to come for elective surgeries without the appropriate screening and risk stratification, you run the risk of higher readmission rates, of unequal outcomes, of a lot of, far bigger complications down the road. So I think, for most of the investments like this pay for themselves within, a 6-month period. So I don't think we're talking about, it's some significant change in workflows. On the other hand, this is probably the best time, the time to really implement changes in workflow is when there's a big shock to the system, right? So there is not a current normal right now. And so this is the time to seize and adopt those practices and those changes that are going to work. When everyone's doing fine and, surgeons are filling their ORs regularly, like trying to talk to them about, hey, we should use some artificial intelligence to better stratify how much pre-surgical, who gets a longer physical exam before surgery. They're like, I'm full for the next 4 weeks. What am I worried about this for, right? Now that sort of, again, I don't want to be flip about it, but never let a good crisis go to waste, right? And this is the time to implement big, bold workflow changes, because you're not going to run up against a lot of, oh, everything's just fine, why are we doing this, right? It's like, okay, if this is what's going to work, let's try it, let's do it. So I think this is really an exciting opportunity in some ways to implement these more resilient and these better workflows going forward.
Absolutely. So I just did want to run another quick poll question among our attendees. What do you think will recover the lost revenue due to COVID-19 at your organizations? Do you feel like the situation is in control and revenue will recover soon? Do you see efficient patient engagement program as key to boosting your surgery volumes? Do you have, or do you think a robust virtual care program is key to drive revenues? Or do you think that a revamped IT infrastructure itself to help you transform your operations digitally is the key to recover lost revenues?
Right. And all of the above is not an option. So I think we're asking people to put the one that they think is going to be most impactful.
Absolutely.
So Evan, let me ask a question while we're waiting for the audience. You know, a lot of folks have made investments in things, their EMRs, their practice management system. They may or may not get claims data from one or more of their you know, insurers for their patients, but they don't know how to put all that together. I saw that last slide with all these data sources. Maybe speak a little bit about how folks should think about this.
Yeah, I mean, again, it depends on the size of the practice. It depends on how much the practice is at risk or trying to really sort of embrace the, you know, patient-centric medical home approach if they're a primary care practice. But finding a way to have a single source of truth, a longitudinal record on patients that includes claims data and EHR data and data from other care settings can be incredibly valuable, right? And certainly that's what we're all about at Innovaccer, but not every practice has that right now, or feels that it's important for how they're practicing.
Yeah, and I think being able to do that these days without having to rip and replace investments you've already made is a really awesome approach. Be really interested, Kishan, to see what our audience thinks about this.
Yeah, well, I think 60% of our audience basically believes that a robust virtual care program is what is key to driving revenues.
Option 2 won both polls with 60%. This is interesting.
Yeah. And 30% think revamped IT infrastructure to support the digital strategy is key. I think all of you said that. I think Evan, you mentioned that you don't have an option. That's the only way to go forward, right? And about 10% actually, interestingly, feel like the situation is in control and the revenue will just recover soon by itself.
Good.
So, yeah, pretty interesting insights there.
Which, well, so, considering 7% said there was no impact, that's actually a very small number, right? If we go back absolutely. To the earlier poll. So it's really just a very small percent feel like it's rebounding on its own. It's actually one person based on our current attendees, I think.
Yeah, a little more than that, but yeah. So Evan, we've got about 3 minutes left. So I thought I want to definitely talk a little bit about more tangible ways in which providers can think about regenerating revenue. So what, in your view, are the low-hanging fruits that most providers can go after as they start engaging patients and picking up patient volumes?
Yes. So the lowest hanging fruit is doing things virtually that you used to do in practice, or like so I don't know how many practices on the phone are billing 99490 chronic care management, but Medicare and commercials will pay $42 a month for work that's not even done by a physician, right? If you're spending more than 20 minutes coordinating care, whether that's a phone call, prescription renewals, responding online to cases, right? As long as you have a timer and can track that you spent 20 minutes per month, and for most patients with sort of 2 chronic conditions, there are a lot of practices that spend a lot more than that. It's a good way to get paid for the work you're already doing. The other number that's shocking is how few Medicare patients get an annual wellness visit. And again, if you want to know the right email, I'll give away trade secrets, but the right email text to use is your free Medicare visit is coming up, right? Because the AWV is the only Medicare visit without a copay. And patients like to be reminded about it. Not all of them will do it, but it's always nice when you actually get paid for doing the right thing. And I think the annual wellness visit is the right thing. Chronic care management is the right thing. We can talk a little bit about the TCM and RPM code. You know, the transition of care management is basically if you schedule a visit right after someone is discharged from the hospital, and then see them within a week or 2 weeks, you can bill a lot more than just a 99213, which would be, you know, or 99214. So it's sort of $60 to $70 of incremental revenue. And, you know, I've looked at data from a lot of health systems. They're actually doing, they're meeting all the criteria to bill a transition of care visit, but because they don't have the right workflow in place to identify that they contacted the patients within 2 days of discharge and that they then had the visit, they're losing $60. They're just like, it's just like throwing away $60 because that's a case where you could have just coded a TCM, but you know, not all coders know about it. There's a lot of things. Remote patient monitoring, the last 3 codes in the lower right there. You know, if you're doing really well on the first 3, then start going after RPM. But you know, I think this is very much in order from easiest to most challenging, right? If you don't have a good annual wellness visit program, put one in place. It pays for itself. The patients find it rewarding. It's the right thing to do, and you actually get paid. After that, chronic care management. You know, most primary care practices I've seen 10 to 30% of their patients would really benefit from a CCM, in some cases higher, in some cases lower, and are very, very receptive to it. And again, it does require some workflow changes, right? The practices have to actually track the time they're spending. But it really, when you look at all the time you're spending, whether it's reviewing lab results, especially if you've got patients on, you know, warfarin, Coumadin, time spent on prescription, MedRec, diet advice, any number of things that most practices are doing anyway, but not getting paid for. It's a very good way to ensure you're getting the revenue in.
Absolutely, excellent. Well, this has been a great discussion. Thanks, Dr. Nace. Thanks, Evan. We're nearly at the end of the webinar, but I really hope that all our attendees here found this a very informative session, and you have something to take back as you go back to your organizations. Thank you once again. Thanks a lot for all your time and effort.
Awesome.
Thank you all.
John, I bet your audience would love if you would send, particularly this last slide, maybe this information to them, because I think there's so much immediate revenue people can generate right here.
Absolutely. We'll be sure to send this back as soon as we end the webinar. Thank you.
Thank you.
Thanks.